More than 20 years after our epilepsy surgery program was started at the Claudio Munari Center in Guarda Hospital, Milan, we wanted to describe retrospectively our SEEG activity, reporting on indications, surgical technique, complications, outcome predictors, and results on seizures. Our sample included 713 SEEG studied patients. 29 patients were investigated twice, for a total of 742 procedures with 10,084 implanted electrodes. Only 16% of investigations were bilateral. The use of SEEG progressively decreased in patients with MR visible lesions, with a parallel increase of MR negative cases. Overall, the mean number of electrodes per implantation was 14, with an increasing trend throughout the years. Reluctance to consider MR negative cases for surgery was progressively mitigated by evidence of epilepsy-related focal abnormalities provided by novel diagnostic tools, including PET scan, image processing, and high-density EEG. These tools frequently provide additional working hypotheses, thus expanding the areas to be covered with electrodes. Planning images are post-processed to make the trajectory planning easier and more efficient. FreeSurfer is adopted to segment the brain and estimate the pile surface. Catheter angiography is obtained in frameless and markerless conditions with the mobile cone beam CT scanner, days or weeks prior to the implantation. Vascular images are processed and registered to MR with FSL. Trajectories are planned on both multiplanar and 3D surface reconstructions. The Stylet frame is used as a rigid head holder. Next, the head holder is fixed to the robotic assistant. The Neurolocate, a new touchless registration tool, is approached close to the head of the patient. A 3D cone beam CT is then obtained to register the head of the patient. One by one, the robotic arm aligns the tool holder with the vector of the planned trajectories. The skull is twist drilled percutaneously. The dura mater is opened with the monopolar coagulating electrode. Then a guiding screw is advanced into the skull. Once all the guiding screws are positioned, the electrodes are implanted under X-ray control. First, a rigid stylet is advanced all along the trajectory. Next, the stylet is replaced with the multi-lead recording probe. Finally, a post-implantation CT is obtained and registered to preoperative images. Multimodal scenes are then helpful to assess the correct position of every recording lead. A recent meta-analysis showed that our submillimetric accuracy at the cortical entry point, the true risky zone, was the best ever reported. The overall complication rate was lower with the new workflow compared with the traditional procedure, even if not significantly. None of the major bleedings occurred with this new workflow. Glioneuronal tumors, type 2 FCD, balloon cells, hippocampal sclerosis, and PNH reduce the risk of seizure recurrence at least by half. Also, older age at epilepsy onset reduce the odds of unfavorable outcome. On the contrary, negative MR and lesion remnant increase the risk of seizure recurrence by at least 1/3. Notwithstanding the progressive increase of the proportion of MR-negative patients, seizure outcome did not worsen throughout the years. We can conclude that SEEG contributes to excellent results on seizures in the most challenging patients suffering from drug-resistant focal epilepsy, and its efficacy and safety profile justify the widespread of this methodology.